Has elapsed. Hello. Good afternoon. Welcome to our Grand Rounds program. Today you see I'm introducing our speaker in lieu of our usual and beloved Dr. Hallberg, because I wanted to have the opportunity to introduce Dr. Van Schooneveld, and I hope I did a good job with the last name there. He's no stranger to these talks. He's been here before. Today our topic is the application of antimicrobial stewardship principles to skin and soft tissue infections. Do I really need to give everyone vancomycin? Well, quite a long title that Dr. Van Schooneveld has worked on us because of multiple requests and multiple objectives that we wanted to accomplish today. We want to introduce the crowd to the concept of antimicrobial stewardship, and of course we want to talk about very common diagnosis in this regard, which is cellulitis. Dr. Van Schooneveld has very excellent academic track record. He graduated cum laude in his BS for biochemistry. He graduated high distinction from medical school in the University of Nebraska, and he did his postdoctoral training in internal medicine and infectious diseases in the University of Nebraska. He's currently assistant professor and associate program director at the University of Nebraska for the infectious diseases program, and he's involved in a number of research projects as principal investigators, all related to wise use of antibiotics. I want to highlight that Dr. Van Schooneveld was part of the committee from Infectious Diseases Society of America writing the guidelines for antimicrobial stewardship, that's a document that I visit frequently. So without further ado, I leave Dr. Van Schooneveld today with his presentation.
Great. Thanks. I appreciate the kind introduction. Thanks for having me back. I survived the torrential rains between Omaha and here. So it is a long title, but I tried to, application of antimicrobial stewardship, skin soft tissue infections. It sounds a little dull, so I tried to jazz it up with a nice clinical question. We're going to spend the first about 10 to 15 minutes talking about why antimicrobial stewardship is important. Why should we care about how antimicrobials are used? And then we're going to take those principles and why we should care and apply them to how we utilize antimicrobials for a common problem we all see frequently, skin soft tissue infections. So just to remind you where we've come from, antimicrobials have radically changed how we practice medicine. I mean, I guess no one here practiced medicine in the pre-antimicrobial era where we had nothing to treat infections beyond surgical therapy, when we could give people medications but we had no confidence that they would be effective. With the introduction of antimicrobials, we entered a new era in medicine where we had drugs that would effectively treat infections. This is some of the data that shows that. So this is Erysipelas, or simple strep cellulitis mortality at Cook County Hospital in Chicago. You can see in the pre-antibiotic era, it runs between 11 and 18%. Antibiotics introduced rapidly dropped. This is data from Norway. Same infection. For some reason, they have data back to 1880. I don't understand why. It's Norway. I guess I shouldn't be surprised. But this is the same mortality on a per 1,000 patient basis. You can see with the introduction of antibiotics, it drops to basically zero. And we just don't see people die of strep cellulitis because we have lots of antibiotics that would treat it very effectively. But this is the problem we have. While antibiotics have been used and have really radically altered how we do medicine, this is the problem we have as antimicrobial resistance. This is not a new phenomenon, though. This is time from 1994. So this is not a newly recognized problem. The CDC, though, felt this was such an important problem that they should put together what they call their antibiotic resistance threat report, which actually came out just last month before the government shutdown. And in it details over 100 pages of some nice flashy graphics. But they detail out the impact of antimicrobial resistance, and then they basically divide pathogens up into things that I really need to worry about right now, things that are bad but aren't a humongous disaster, and things that are waiting in the wings to become a huge disaster. And in that, they basically come up with what they consider a floor figure for what the impact of antimicrobial resistance is. And in a very conservative estimate, they estimate about 23,000 people die of antimicrobial resistant infections, and over 2 million people become ill per year. They also mention C. diff, and I think this is important whenever we talk about antimicrobial stewardship, and that antimicrobial use is the predominant risk factor for developing C. diff, and that results in 14,000 deaths per year. If you look at antimicrobial resistance, it varies. Are we having some problems with our microphone here? We're doing all right? All right, I thought I was hearing a little feedback. It varies depending on where you're at. So if you look at MRSA, for example, we have MRSA, depending on where you look at it, how you measure it, somewhere up to about 50%. If you looked overall at my institutional antibiogram, it's about 50% of staff are methicillin resistant. Now that's much worse in places like in the Far East, and much better, much lower rates of MRSA in Scandinavian countries, Netherlands, Switzerland, where it's less than 5% or less than 1%. But if you were to say, look at a different pathogen, extended spectrum beta-lactamase producing E. coli resistant to third generation cephalosporins. Again, not a huge problem across the US, some areas higher, but if you were to look, say, in Southeastern Asia, a third of people in Cambodia, outpatient UTIs due to ESBL E. coli. In India, 80% of E. coli, ESBL producers, community and hospital. And so depending on the pathogen, resistance rates can be very high. Where does all this resistance come from? Well, as you know, bacteria exist in a population, and typically in that population, there's a small number of bacteria that are resistant by mutation, by, having picked up a gene from somewhere. And then those bacteria are exposed to an antimicrobial either in the hospital or in the clinic, leading to killing off of all the susceptible bacteria and selection for a bunch of resistant bacteria. You now have a resistant population. Now, one thing I think that's important to keep in mind is that this antimicrobial exposure doesn't just happen to bacteria in the clinic, but it happens in agriculture. And actually, if you look, 80 of all of the antibiotics by tonnage, 80% of all antimicrobials are used in agriculture, primarily as growth promoters. And so people have tried to quantify what's the effect of this. And this was an interesting study that was just published. I would consider it suggestive, not definitive, but in this they looked at the contribution of high-density swine and dairy operations to MRSA skin soft tissue infections, and the application of manure from those operations to crop fields. And they basically, in a healthcare system, looked at almost 3,000 patients with MRSA skin soft tissue infections, and they did a case control study trying to tease out the amount of contribution of their proximity to these operations. And they used these state-required nutrient management plans, or what you're going to do with all the manure from these operations. And they looked at it by location, animal type, quantity, and amount of manure. This is basically where they looked at it. Each one of these green dots is a crop field. These are the areas of MRSA with increasing darkness, with increasing prevalence. They used Google Earth, interestingly, to locate and confirm the location of all these facilities and of these crop fields. And what they found is that basically, to sum it up in a rather complicated study, was that proximity to and the size of the high-density operation were associated with MRSA infection and with skin soft tissue infection overall. And the population attributable, or basically the amount this was contributing to all of it, was over 10% of MRSA infections and over 10% of skin soft tissue infections. And so I think, what's the take from this? Well, we can't use that many antimicrobials in agriculture without some sort of consequence. Is it specifically an MRSA? I'm not sure, but we can't do that without consequence. So antimicrobial use is the key driver of resistance. And actually, it's not a newly recognized phenomenon. Alexander Fleming, in his Nobel Prize speech, actually commented on this. It's actually a very interesting speech. I'm going to show you just a tiny bit of data to justify that use drives resistance. So these are, in each of these blue dots, a European country. This is penicillin use by country. This is penicillin resistance in strep pneumo, most common respiratory pathogen. You can see there's a very nice correlation between use and resistance. France, they use a lot of penicillin, they have a lot of resistance. The Netherlands, Denmark, they don't use as much, they have much less resistance. And I think this slide I like because it brings home the individual patient and the duration of the effect of this antimicrobial use. In this study, they had some groups, about, I think, 20 people in each group. They gave 2 of the groups placebo, and then for all the groups, they cultured their mouth to see what % of their oral flora resistant to macrolides, because they gave the other 2 groups macrolides. What you could see is about 30% of oral streptococci are resistant to macrolides. That's about baseline. Didn't change much over the study. Those exposed antimicrobials had rapid selection, where most of the bacteria isolated after being exposed to antimicrobials were resistant to those antibiotics. But the important thing I would point out here is the duration of that effect. Significant at 2, 4, 6 weeks, and even at 6 months, people still had more resistant bacteria isolated. And so the impact of antimicrobial exposure is prolonged. And I'm not going to show you the data, but it is also individual patient specific. So a patient exposed to an antimicrobial has an increased risk of having an antimicrobial resistant infection after that exposure. So you say, big whoop, we got other antibiotics, we'll just work through it, we'll just, it doesn't matter. Well, I would suggest it probably does, that resistance is bad both for our patients and for our healthcare system. This is a meta-analysis, a summary of 31 cohort studies comparing MRSA versus MSSA bacteremia. What you can see here is if you had MRSA bacteremia, you were about twice as likely to die compared to MSSA bacteremia. That raises a question of why does resistance worsen outcomes? And that's a complicated question to answer because it might be different for different pathogens, but I think this slide points out one of the reasons resistance worsen outcomes. If you look back at the previous study, you'd say, well, we were using an inferior antibiotic. Vancomycin is clinically inferior to beta-lactams for Staph aureus bacteremia. Now, if it's resistant to beta-lactams, you got to use what you got. But in these are 6 different studies that looked at outcomes of patients with severe sepsis, septic shock treated in an ICU. And what you can see, or not a surprising finding, is that if people didn't get antibiotics that were active against their infection, they were more likely to die compared to those who got antibiotics that was active against their infection. It's sort of a no-duh moment. The question is, why did people get antibiotics that didn't work? Were the doctors boneheads? I would say they were not. These are actually performed in 6 different tertiary care, excellent, high-quality academic ICUs where people were prescribed antibiotics per typically their usual practice for that facility. Why did they get inappropriate antibiotics? Because the pathogens were resistant. And so resistance can make us look foolish. We think we have someone on the right antibiotic, but they aren't. And this is particularly important for those who have severe illness. Maybe less important for those who have less severe illnesses, but particularly when looking at mortality, choosing the wrong therapy due to resistance worsens outcomes. And this is not only bad on an individual patient level, but bad for our healthcare system. In this study, one center over 1 year, they looked at 188 antimicrobial resistant infections, so MRSA, VRE, resistant gram-negatives, and they compared them to about 1,400 patients who didn't have resistant infections and other sorts of infections. And people have said, well, people with resistant infections are sicker than those who have susceptible pathogens. And so they looked at severity of illness. And what they found is that it didn't matter whether you were mildly ill or severely ill. If you had a resistant pathogen, that's what ARI means, antimicrobial resistant infection, you were more likely to die. And then they looked at the costs associated with these infections, and they found that the costs were between $18,000 and $29,000 additionally, with 6 to 12 additional days of stay, 6.5% attributable mortality, and for those 188 patients, an additional $13 million that they spent treating those resistant infections. So, bad for patients, bad for our healthcare system. This is the next problem we have. We are rapidly running out of antimicrobials. A couple reports from the Infectious Disease Society of America, one highlighting this, one with some strategies to help increase drug development. This is drug approvals for anti-infectious agents. If I were to show you oncologics, it's about 20 per year. And so we're rapidly running out of antimicrobials for a variety of reasons. The main one, I think, being that antimicrobials aren't big money makers for drug companies, as opposed to cholesterol drugs, antihypertensives. The final problem we have is antimicrobial misuse, and that nearly 60% of all patients are going to get an antibiotic. And when you look at it, depending on how you look at it, how you qualify it, about half of that use is either inappropriate or unnecessary. If you look in long-term care facilities, at any one time, over 10% of all patients in long-term care facilities are on antimicrobials. And all this leads to selection for resistance, which we've talked about, collateral damage, things like C. diff, toxicity and side effects. If you come to my ID clinic, it's people suffering the side effects of chronic antimicrobial use, and then overall increased cost. And so what are we going to do? Well, we're obviously not going to create new drugs, so we have to learn to use what we have more wisely. That's where the idea of this antimicrobial stewardship comes into play. And I think if there's anything you take away about antimicrobial stewardship, it'd be this one slide, because I think what we need to have is sort of a paradigm shift in how we think about antimicrobials. Because these are really unique drugs that aren't like any other drug that we utilize. They're the only drugs that lose efficacy over time and have to be replaced. It's metoprolol, it's an old drug, it's generic, still work for blood pressure? Yeah, it works all right. There are other beta blockers, maybe with different side effect profiles, longer action. Still work? Yeah. Does penicillin still work? I don't think so. Doesn't work anymore for most of the infections we used to treat for it. They're the only drugs where we have to use them sparingly to prolong their efficacy. If we put statins in the water, 2 or 3 years, would they suddenly stop lowering cholesterol? We'd have to come up with new drugs? No, they'd still work. If we put fluoroquinolones in the water, would they cease to be effective? We are, and they are ceasing to be effective. Nationwide fluoroquinolone resistance rates in E. coli are approaching 20%. They're the only drugs where we actively discourage use when new drugs are approved. Guys like me come along and say, well, that's great, a new drug, but let's save it for when we really need it. This is another reason the drug companies are not very excited about bringing out new drugs. And they're the only drugs where how I utilize them can actually affect your patients. And that if I misuse anti-neoplastic agents, I'm treating my tumors all wrong, way overusing carboplatin, your tumors don't become resistant to anti-neoplastic agents, but if I misuse antimicrobials, my patients develop infections with resistant bacteria. They can easily spread to your patients, and then despite your good use of antimicrobials, you can suffer the consequences of my misuse. And so we really need to shift how we think about antimicrobials into sort of thinking of them as like a shared natural resource, like a forest, or a fishery, that if, you cut down all the trees, catch all the fish, what's left for future generations? Well, a lot of nothing. It's the same thing with antimicrobials, and that we really need to think of them as a resource that needs to be preserved so we can still use them 20 years from now. So what is antimicrobial stewardship? Well, antimicrobial stewardship really refers to processes designed to optimize antimicrobial use. It'd be great if everybody could have an ID doc like you guys have here, and a program, and an ID pharmacist, but that isn't available everywhere. And so it's really processes designed to help physicians decide when should you use antibiotics, what dose, and what agent it would be best, and then how to dose it, what route, what duration. And the goal is really focused on patient and public health. How do we cure and prevent an infection while minimizing toxicity and resistance? Now, if we do those things, we're going to reduce treatment costs. And this is where hospital administrators get real excited. They say, well, we can shorten length of stay. We can, improve, have less resistant infections, less C. diff. That's great. But I think the focus really has to be on these things first. And if we do those things right, we really will impact these. So what are the strategies? These are what the guidelines recommend. I'm not going to spend a lot of time talking about these, but the key is multidisciplinary involvement, having multiple people from wherever you're at, whoever's available, ID, intensivists, hospitalists, microbiology, infection control involved in helping to develop these processes. There's some primary strategies advocated: restriction, sorry you can't have that drug; pre-authorization, well, you want it, but you got to call somebody and get it approved first; or prospective audit and feedback, which is what we do a lot of you can start what you think is most appropriate, and then we'll come along behind and help you sort of tweak it in the way we think is most appropriate. Education is important, although not super effective, but I think important to get your message out there over and over again. Institutional guidelines and pathways, de-escalation protocols, dose optimization, good for both patient treatment and for patient safety. IV to PO conversion, I'll comment on in a minute. Antibiotic cycling, we don't really do anymore, switching from Tobra to amikacin to gentamicin every 6 months. And then these aren't in the guidelines, but I think if they were written now, they would be included. The use of computerized physician order entry and associated clinical decision support. As we all transition to electronic medical records, I think this is the way stewardship is going in the future. And then indication and duration. So the CDC has been pushing this for quite a while. They have their antimicrobial timeout that they recommend at the starting of antibiotics, and that all antibiotics should have a dose, a duration, and indication. So you'd say, well, why should it have an indication? Well, we live in an era of hospitalists, frequent transitions of care, frequent handoffs. And I got to tell you, I've read a lot of notes in my institution, and I read notes, and boy, if I read the notes and tried to guess why people were on antibiotics, I would not make a lot of headway. They're on for sepsis, fever. What are they actually treating? I don't have any idea. When you put an indication that doesn't include things like sepsis and fever, you make people, the goal is really to prompt people to think about, what am I really treating? Treating pneumonia. Well, maybe daptomycin isn't the most appropriate antibiotic for pneumonia because it doesn't actually work for pneumonia. It improves communication. It prompts clinicians to think about why we're doing it. And it also allows people in stewardship to come back and say, well, okay, so they say they're treating a UTI. Maybe we need to actually dose adjust what we're doing here. So a lot of reasons I think indication is useful. Getting cultures before you're starting, this is a key thing. And then once the data comes back, reassess. Do I need the antibiotics? Did this turn out to be heart failure and not pneumonia? Can I just chuck all the antibiotics? Can I narrow down? And really taking that time out. And they borrowed this from the surgical literature because it's worked well. What's coming in stewardship is probably a requirement for stewardship. It's not here yet. This is the draft CMS survey from 2011 for acute care facilities. This is in the infection control component. They had some survey questions in here. These have not been rolled out yet. They're not required yet. But I would not be surprised if these make an appearance in the next couple of years. That has been the policy position advocated by the Infectious Disease Society of America, Society for Healthcare Epidemiology of America, that these be mandated in some way. What are the things that are in there right now? Well, basically that you have a stewardship program, a multidisciplinary process that reviews use and that people are sort of following that process. The problem here is you're trying to sort of take this from everywhere from, the critical access hospital up to the tertiary care academic facility. And the resources available at those facilities are very different. And so that's why I think processes are the key thing to think about here. A process to prompt clinicians to use appropriate antimicrobial agents, and they have a whole bunch of ideas there. Indications, it's already required for PRNs. Wouldn't surprise me if this comes quite soon for antimicrobials. A mechanism to prompt review at 72 hours. There's that antibiotic timeout. A little more difficult. How do you do that? Well, they didn't specify. I think what they'll eventually be looking for is that you have something. And then that there's IV to PO conversion. So IV to PO conversion is frankly your pharmacy director's best friend because it helps his budget. It also gets people out of the hospital earlier when done in a safe, appropriate manner. All right, so that's the principles of stewardship. We're going to spend the last 25 minutes talking about the application of that to skin soft tissue infections, which are common problems. We all see these regularly if we see patients. And we're going to work our way from superficial, from the epidermis to deep to the subcutaneous tissue. We're going to talk about epidemiology. And I'm going to start off with sort of the ID doc's way of thinking about things. The first question the ID doc asks when he walks in the room is it really an infection? And I think that's a key question. We're going to, at the end, talk about cellulitis mimics, because I got to tell you, about half to 2/3 of the people I see for refractory cellulitis don't actually have any infection at all. And so I think it's important to think about those things. And that's always the first question in the ID doc's mind. Is this really an infection? The next question is, how bad is it? Is it a deep infection? Is it a very superficial infection? Then, as ID docs do, we think about what are the exposures. Oh, did you, were you in a bat cave, going through bat guano? Were you, in the southwestern U.S.? All those good questions we ID docs like to ask. And then what's the immune status of the patient? Is this a bone marrow transplant patient who has 0 neutrophils? Is this a healthy, normal person? And then taking all that into account, we think about the epidemiology of the bacteria. And that's why I'm going to emphasize epidemiology of infections, because if we think about what are the bacteria that causes it, it's going to help us to direct our therapy. And so we're going to start from the epidermis in. Impetigo, very simple, outpatient problem, staph and strep. Starts as a vesicle, rapidly pustulates, ruptures, causes classic golden yellow crust. It's painless. Topical therapy is all you need for this. Mupirocin, there's this new retapamulin, topical antimicrobial, which is in trials now as an IV formulation, very active against staph and strep. When would you use oral? Well, would use oral when it looks like this, when it's bullous impetigo, severe impetigo. Then you're going to want to use something typically active against strep and MSSA, because those are the classic pathogens. If there's a concern for MRSA, and I don't think this has been well worked out when you should add anti-MRSA therapy, people are known to be colonized, I think it's pretty reasonable to add an antibiotic active against MRSA. Erysipelas. So this was a fantastic patient I saw last month, and I was terribly excited about his facial erysipelas. The residents were rolling their eyes at my enthusiasm, but you just don't see people with erysipelas very much. This is an infection of the upper dermis and the lymphatics, but not down in the subcutaneous tissue. It's this painful, sort of fiery red, well demarcated, you can see very nicely demarcated, raised, indurated. You could actually tell, until I felt it, I couldn't be sure it was erysipelas, but you feel it as this sort of indurated, almost slightly woody feel. It's clearly raised. This is classically group A strep, and penicillin is really the drug of choice here. Although if someone who has known MRSA colonization, again, you might consider some anti-MRSA antimicrobials. But typically this is going to be due to group A strep. Well, let's move on and talk about abscesses and cellulitis. And so you're going to get some good gross pictures because, you can't do a skin soft tissue infection without gross pictures. So abscesses we're going to start with. So this is not news to anyone. Community-acquired MRSA is widespread in the community. This is from the mid-2000s. This was a survey of culturable infections in the ED, which are typically things with pus or abscesses. It was 60% community-acquired MRSA. And community-acquired MRSA showed up in the early 2000s, basically spread throughout the country, and makes up the vast, 50 to 60% of the Staph aureus we see. Now, some more recent data, which I'm not going to show you, suggests that maybe that's kind of peaked off and starting to decline a little bit. The impact of that, though, is tremendous. And that you can see, these are the number of U.S. ED visits for skin soft tissue infections over the mid-2000s. More than doubled. I remember I was moonlighting as a fellow in the VA admitting area, and we would lance 2 to 3 boils a night. People just roll in with skin abscesses. And it was all due to community-acquired MRSA. And the ER docs caught on to this. And so they gave a lot of antibiotics for community-acquired MRSA. And so you guys are all familiar with these skin abscesses. They're not spider bites, despite what people say. Everybody always thinks it's a spider bite. And actually, if you look at the brown recluse, and I should have included the slide, the brown recluse, basically where it lives, sort of ends about here. So somewhere about Omaha, Des Moines is where the brown recluse stops hanging around. Now, nobody tags brown recluse spiders and nobody tracks them officially, but basically this is the borderline of the brown recluse area. A furuncle, you guys know this, probably from medical school, inflammatory nodule in the subcutaneous tissue, something like this or this. A carbuncle is multiple sort of coalescent ones. These are due to Staph aureus. MRSA, almost exclusively now, although MSSA is starting to come back a bit. Now, if you have other unique locations, say perirectal abscess, that certainly would be more gram-negatives or anaerobes, but your buttock abscess is going to be MRSA. Treatment of these, incision and drainage. The question is, do we need antimicrobials? And that's, I think, an important question to ask. So that's been studied, 3 placebo-controlled randomized trials looking at antibiotics for skin abscesses, where basically all of the studies were about 70 to 90% Staph aureus, and the Staph aureus was 70 to 90% MRSA. And so in this cephalexin trial, it's pretty much all placebo, because, Keflex doesn't work for MRSA. What you can see here is that the outcome with antimicrobials, whether they were active against MRSA or not, didn't change outcomes. There was maybe some suggestion of maybe decreased recurrence if you use Bactrim, but that was only one study and not a very strong suggestion. And so the takeaway of this is antimicrobials, if you drain an abscess, don't really add much. And that's actually, if you're going to read any guideline on skin soft tissue infections, I would direct you to this MRSA treatment guideline from the IDSA. It's a fantastic guideline, and I'm going to reference it a couple of times in how to treat skin soft tissue infections. The skin soft tissue infections, the guidelines that exist right now are being rewritten. They were published in 2005, and so they sort of predated the explosion of community-acquired MRSA and some of the studies I'm going to show you. But they basically say IND is the primary therapy, and you don't need antimicrobials, except when it's really bad. Someone has systemic signs of infection, they've got fevers and chills, reasonable to give an antibiotic. Someone is immunocompromised, and I'll tell you, these are all expert opinion level advice. So this is sort of a bunch of smart guys got in a room and said, well, this is what we think seems reasonable. There's not data to really support this. The extremes of age, very young, very old, for the same reason as immunocompromised. Places where you can't drain it, or it's a sensitive area, an abscess on the face, hand, genitals, you really don't want that getting out of control. That's a very sensitive area. And so antimicrobials are very reasonable there, or when people fail an IND. And the agents there are Bactrim, trimethoprim sulfa. Now, 1 to 2 tabs BID, different people have different opinions on this. My opinion is 1 tab twice a day is adequate for the vast majority of people. For really, really big people, which we run into frequently, then you can consider 2 tabs. But there's some nice literature actually where they had diabetic feet and they gave them Bactrim and they actually took tissue samples of debridement and measured the levels of the drug in the tissue, and they were pretty good on one tab twice a day in a diabetic foot, which is not the ideal situation for drug delivery. So I generally use 1 twice a day unless I'm really worried that someone's really big. Clindamycin, somewhere in 300 and 450. The higher doses can sometimes bring on diarrhea, and then doxycycline, minocycline. I would say any of those are fine. You should know your local clindamycin resistance rates, though, because they can vary significantly. All right, so I think this study that Tim Jenkins did at Denver Health is a really nice study to talk about because it looked at how do we do using antimicrobials for skin soft tissue infections. And they did a retrospective study at Denver Health, which is a county hospital there in Denver, and they looked at the treatment, the imaging, the microbiology of skin soft tissue infections. And they found that the epidemiology was primarily what we thought. It's staph and strep. And in fact, in over 70% of the patients, they were the only pathogens isolated. And one of the nice things from this study that I'll point out is that they looked at the use of imaging, which my take from this is, wow, people do a lot of images. I mean, it amazes me the amount of images. And then the thing to point out is, what is the yield of all that imaging? I would say it's pretty stinking poor. 1% for plain films. Now, I would argue that if you find something on plain films, an osteo, gas in the tissue, that's a pretty significant finding, and the cost of a plain film is pretty low. But ultrasounds, less than 0.5% yield of an ultrasound, CT and MRI, 2 or 1%. And so I think we vastly overutilize imaging. At least at my center, we overutilize imaging for skin soft tissue infections. Now, should we use it at times? Certainly. People where the diagnosis is unclear, maybe we're concerned about a necrotizing fasciitis or some other process like that. If somebody's not responded to therapy, I think those are places where very reasonable to use imaging. But I think we probably overuse it. But I'm not talking about radiologic stewardship. I'm talking about antimicrobial stewardship. And so there are opportunities here. And so what he found is there's a lot of vancomycin use, not surprising. But the thing I would point out is 60 to 80% of people got broad spectrum gram-negative therapy, Piptazo, Amsulbactam, carbapenems, fluoroquinolones. 3/4 to 83% got anti-anaerobic therapy. Remember the epidemiology, it's staph and strep. Over half of people got 3 or more antibiotics for their infection, and the median duration of therapy was between 10 and 14 days. Now, this was simple cellulitis, cutaneous abscess, and this was basically anybody who wasn't one of these, diabetics, peripheral vascular disease, surgical wounds, all that other stuff. The guidelines say, there's good studies that 5 days of antimicrobials are adequate for cellulitis. 5 days was no different than 10 days. Now, there are situations where we might use a little longer. Cutaneous abscess, there's good literature. We don't need any antimicrobials. And so I think this is the key area where we vastly overuse broad-spectrum gram-negatives. I don't know how it is at your institution, but a lot of the patients I see, they get vancomycin. And they get vancomycin for everything. UTI, skin soft tissue infection, pneumonia. It's just good for everything. I've at least got them to stop using Cipro with their vancomycin, which I'll take as a minor victory. So is that all necessary? Well, let's talk about cellulitis. Cellulitis, you've all seen it. It's this tender, painful, spreading erythema, fever, chills. There can be some swelling. It involves the deeper dermis and subcutaneous tissue. It's not typically elevated. It's indistinct, as you can see here. You can get an idea of where it ends, but it's not like that erysipelas I showed you. Can be patchy. Here, this looks almost clear in the center. and can have associated lymphadenitis or ascending lymphangitis. The microbiology of strep of cellulitis has classically been beta hemolytic strep, group A, group B, group C, group G. The problem is it's really hard to sort out the microbiology of cellulitis. Blood cultures have a yield of 1 to 3%, and there's really nothing to culture. People have tried, leading edge aspirates, skin biopsies with cultures. Man, aspirates of bulla, those are really low yield, on the order of the same as blood cultures. And I've been very disappointed, despite having utilized them at times. And so people have tried to sort out what's the epidemiology of cellulitis. And this was, I think, a fantastic study that looked at this. A prospective study of non-culturable cellulitis, i.e. there couldn't be pus coming out of a wound, because then you could culture it. Single center, academic center in California, and they tried to sort out what percent of these infections are due to beta hemolytic strep. And they did that using blood cultures, which had a yield of about 4 or 5%, and serology, ASO titers, DNase B, and as you probably know, those are not fantastic ways to do strep diagnosis, but they're frankly the best we have. And they did, they did added time of infection, and then they had them come back 4 weeks and did pre and post titers to really try and sort this out. And doing that, they were actually able to sort out that 3/4 of the infections were clearly due to beta hemolytic strep. They also tried to shunt people to primarily using beta-lactams, mostly cefazolin, and they had a 96% response rate to beta-lactams. And in those patients who specifically had negative serology and blood cultures, they had a 91% response rate to beta-lactams, suggesting, I think rather strongly, that what we thought before is still the case now, and that most non-culturable cellulitises are due to beta hemolytic strep, and we should be using beta-lactams for them. And so in what was just also published in CID was a trial looking at cephalexin versus cephalexin plus Bactrim, because there's been some retrospective data that suggests that if you didn't use an antibiotic active against community-acquired MRSA, people had worse outcomes. That was retrospective, single center, and non-controlled in selection of antibiotics. And so in this study, they expected to find that using an anti-MRSA antibiotic, adding that on would improve your cure rates. Randomized, blinded, multi-center, placebo-controlled, uncomplicated cellulitis. Couldn't be admitted, couldn't have abscess, could have a wound infection, could have a little bit of purulence, but not more than 1 milliliter. I don't know how exactly they measured it, but those were their criteria. So could have wound infection, but not a lot of pus. And they looked at clinical cure. And they used what I thought was nicely a weight-based dosing, which is another weakness of some of those other studies, in that they used kind of wimpy doses of Keflex. I mean, the approved dose of cephalexin is 500 QID. That's a vast underdosing in the current population we work with. And so they used this dosing scheme, and this is actually the dosing scheme I tend to use myself. And I think it's a reasonable dosing scheme. For those who are small, 500 QID is a reasonable choice. For those who are moderate sized, 1 gram TID. Advantage of that also is it's only 3 times a day as opposed to 4 times a day. What's the downside? Well, cephalosporins are some of our most well-tolerated antibiotics we have in existence. And so really there aren't additional effects of increasing the dose. And then for those who are large, 1 gram 4 times a day. And then they added a weight-based Bactrim, so kind of a lower dose for those who were small, a bigger dose for those who were rather large, or a placebo. And this was the outcome. There was no difference in clinical cure. And if you look back at those abscess studies and other cellulitis studies, the clinical cure rate in cellulitis studies, it runs about 85 to 90%. And you can see they came right in about what the average was. There was no increase in progression to abscess, no adverse events if you use just cephalexin. And again, this suggests beta-lactams alone are adequate therapy for cellulitis. Now, this was a small study, a very specific patient group, but again, I think coupled with the epidemiologic data we have, beta-lactams treat simple cellulitis. The red hot shin is well treated with beta-lactams. And so I'm going to go back to those MRSA guidelines. I think they're fantastic. Non-purulent cellulitis, it's probably strep. Treat them for strep, use a first-generation cephalosporin and anti-staph penicillin, and use a high dose, particularly in those who are rather large or have lymphedema problems. That's where I've seen us have some struggles with treatment success, is you have to use a really high dose sometimes in the big people. Because the tissue penetration into those fatty tissues that aren't well perfused is just really low. Abscess, drain it. if it's in one of those sensitive areas or meet one of those criteria, add an anti-MRSA antibiotic. If it's complicated, i.e. somebody comes in who's really sick, has a surgical wound and burn and ulcer, something like that's infected, those are high risk for MRSA. And so again, a reasonable place to use anti-MRSA therapy. So none of that involves covering gram-negatives or anaerobes. So when should you cover them? Well, this is one situation. A diabetic foot, clear role of gram-negatives and anaerobes in diabetic feet, often a polymicrobial infection. We can often use oral agents, and duration of treatment really depends on a lot of factors. Did your surgeon debride it? Was there osteo? Was there not? Was there staph present? There's a lot of questions, but this is a place where a severe diabetic foot infection, MRSA therapy, anaerobic therapy, gram-negative therapy appropriate. Another place, necrotizing fasciitis. There are two types. There's a polymicrobial, which is usually a mixed strep and gram-negative infection, and then a monomicrobial, which is the classic flesh-eating bacteria of group A strep or staph. And this is a reasonable place to start broad and narrow down. Just to comment on necrotizing fasciitis, pain out of proportion of exam is the key exam finding, and people have been burned on this before. You're looking for this erythema, woody subcutaneous tissue. People can have these big blisters and bullae. They can be very ill, and this is really a clinical diagnosis. It's not very hard to make the diagnosis when it looks like this. You'd hope somebody could figure that one out. When it's a little more subtle, it can be difficult. And I've actually found imaging to be at times detrimental in that it makes the surgeons feel comfortable with not surgically managing these. And so in people who have evidence by clinical and lab, I push for debridement. And I feel like it's one of the jobs as an ID doc is you need to push the surgeon sometimes to do what they're sometimes not super excited to do. But I've seen these go really badly when we've not adequately debrided these. So the key is getting those deep tissue cultures. Surgical debridement is a key, taking your foot from looking like this to looking like that. Although the patient wasn't very happy with that outcome, it did cure her infection. For the type 1, it's using agents like Piptazo, cefepime plus metronidazole, carbapenems, and then maybe adding vancomycin. Type 2 depends on your pathogen, IVIG, hyperbaric oxygen. I'm not going to get into those. People can argue about those all day long because there's not a lot of good data to support them. And there's some data to suggest maybe they're helpful. So I don't know. So let's finish up talking about some unusual stuff. And I think this is where you can really make hay as a doc, is sorting through unusual exposures and mimics. And so one unusual exposure might be human bite. The classic microbiology here is oral strep, staph, gram-negatives, anaerobes, and human bite wounds should be prophylaxed. The human mouth is a dirty place. That person comes into the ER with the punch. They get punched. They have a big cut on their knuckle. Nobody gives them antibiotics. They come back 2 weeks later. They have a draining sinus from their metatarsal head. And so we always prophylax those people with typically augmentin for 3 to 5 days so their hand doesn't look like that. Animal bites. Well, here you have to really consider the animal. And cats being filthy animals, and I'm sorry if you're a cat person, but 80% of cat bites get infected, where only 5% of dog bites. The number of pathogens you get from a cat are rather lengthy, and so I'm not a cat person. Anyway, so the classic pathogens are Pasteurella, also have staph. We think about capnocytophaga causing severe infections in our splenectomized patients. When should you give prophylaxis? Well, whenever there's a deep puncture wound, if there's a moderate severe crush injury like a bad dog bite, anything on the hands or genitals or your prosthetic material or involving a bone or poorly vascularized area, or an immunocompromised patient. And again, it's the same drug, augmentin again. It's simple to remember what to use for prophylaxis. All right, so we're going to finish up. I don't think I put the answers here because it's always more fun to do these when people don't have the answers. And so this is a classic board question for this may have been on my medicine board. So 56-year-old guy with hepatitis C presents with severe cellulitis, left legs, and septic shock. He just returned from a trip to the Gulf Coast yesterday where he sustained a scrape on a seawall while he was swimming. So you guys, anybody? All right, this is Vibrio vulnificans. Don't see a lot of it in Nebraska. Probably don't see a lot of it in Iowa. One of my colleagues who used to practice in Houston, not in Houston, Galveston, did see this regularly. So the treatment is ceftriaxone and doxy. Now this one I've actually seen here. 44-year-old guy has an infection of a left knee laceration he got when he cut it on a dock while swimming in a local lake in Iowa. The infection's severe and rapidly progressive. This one I've seen a couple of times. So this is Erymonas. So this guy cut his knee. This is actually not his picture. The guy actually had a much worse infection. He had a huge debridement and went down into his knee joint, and it was a disaster. And it was primarily Erysipelas. There's a little Pseudomonas in there too. But those are our classic water pathogens. All right, this is a patient I saw in my clinic, a 20-year-old female from Mexico, presents with these progressive skin lesions over the last 3 to 6 months. She said her father, who still lives in Mexico, had similar lesions on his legs, arms, and face. She has no fevers or chills. She hasn't visited any nail salons lately. And I couldn't show you her face, and you couldn't see it anyway, but she has nodules on her face and on her arms. Thoughts? What's that? This is mycobacteria. So this was her skin biopsy, teeming with mycobacteria. This is actually lepromatous leprosy. So I'd never actually seen it before, so it's really nice. So what do you treat these people with? Well, you call the National Hansen Disease Center in Louisiana, and they help you out, get you some clofazimine and a couple other drugs. This patient I saw in my VA clinic, 20-year-old guy, came back from Iraq with these lesions, hadn't healed despite multiple antibiotics. They're not tender. Yeah, so this is the biopsy. This is cutaneous leishmaniasis. So could come back here. We have lots of people who go over to places where they get bitten by sandflies. This is another patient from our center, 46-year-old guy who had AML and undergone an allogeneic bone marrow transplant, had been neutropenic for 23 days, and had this progressive black skin lesion here. You can actually see the biopsy site. It's not a good thing. Yeah, this is mucor. Anthrax could look similar, but because of this guy's status, he got a biopsy, he had hyphae just eating through his tissue, had a debridement that basically encompassed about this much of his arm, but survived. This is another patient, 65-year-old, who'd been on high-dose prednisone for 3 months due to temporal arteritis. She developed progressive nodular skin lesions, a low-grade fever, fatigue. These look a lot like those other lesions. But this isn't leprosy. This is a different mycobacterium, Mycobacterium chelonae. And you wouldn't know it's chelonae. You'd just say, well, this looks like disseminated mycobacteria. And this was just a doozy to treat, too. All right, so this one, this was a good one. Patient admitted 2 days ago for CAP. We were consulted for left deltoid cellulitis. This is her left deltoid. It's painful, it's red, it's hot, it's swollen, and she's on vancomycin. Injection. Yeah, so this is she got her Pneumovax. All right, she got her Pneumovax and her flu vaccine. This is why I don't advocate for giving vaccines when people come into the hospital. Influenza vaccine reaction. All right, so this patient was transferred from another facility. She had chronic liver and kidney disease, progressive lesions over 3 weeks. She didn't have fevers. They were kind of smelly, but she was clinically stable and said they'd just been slowly getting worse. So she'd been on a whole bunch of antibiotics. This turned out to be calciphylaxis due to renal failure. But there was a lot of concern is this an invasive mold infection? This patient was admitted with high fever, high white count, left shift, high eosinophil count. In fact, her eosinophils were 20,000. She had rash on her feet that was non-blanching. She had similar erythema you can see, which is blanching here on her arms, face, trunk, and thighs. So there's a number of things this could be. Vasculitis comes to mind, but this turned out to be a drug reaction due to allopurinol. Pain, swelling, redness of the right arm at the site of previous peripheral IV. That's an easy one. Thrombophlebitis. So this is something we commonly see as opposed to septic thrombophlebitis, which is typically associated with fever and bacteremia. This is treated with warm packs, elevation, compression. This patient has a right leg that's swollen, tender, particularly posteriorly 2 days after returning from a European vacation. They also have a low-grade fever. Yeah, that's an easy one. Looks like a cellulitis, but those calves, when they put the calves together like that, it makes it easy. Another one. These are always my favorite in clinic. A patient referred with recalcitrant cellulitis despite long IV courses, lots of oral antibiotics, active against pretty much everything you can imagine. He has some pain in his leg. It's moderately tender. It's edematous. He doesn't have fever. His white count's normal, as is his CRP. So this is his leg while he's sitting there on the exam table. This is his leg after I lift it up. So this is dependent rubor. This is like a magic trick. People literally are about ready to fall off the table when you do this. It's like my one trick that I have in ID. I can't scope, I can't biopsy, but I can lift people's legs up and tell them they don't have cellulitis. And you can tell them, listen, this is all from your venous disease or your peripheral vascular disease. Don't worry about it. Just manage your other diseases. It's a patient with bilateral cellulitis. I love the bilateral cellulitises, which is recurrent, left worse than right. This is chronic venous stasis. This is classic chronic changes of hemosiderosis. This may lighten up when you raise their legs. It may not, depending on how much hemosiderin deposits they have. But you can see this sort of thick, scaly, chronic venous stasis here. And these can be difficult to tease out. And that's why I show you these, because they sometimes can be very difficult to tease out. And you can get cellulitis in this setting. And so that's where you really have to have a close clinical acumen. When this person doesn't respond to Keflex, maybe I try a trial of anti-MRSA, they don't respond to that. Is this really going to be Pseudomonas? Probably not. That would be very unusual. Now, this was a tough one for us. This patient had this rash despite multiple antibiotic courses. It was horribly painful here. So bad he said, "Doc, just cut my leg off." It's indurated, it's tender, it was firm, and it didn't resolve with elevation. Yeah, so this is lipodermatosclerosis, right? They have this sort of Coke bottle or champagne bottle appearance where you can see they sort of narrow down. This is actually a fibrosing paniculitis, an inflammatory condition that the dermatologists actually have to manage. We manage it and then we get people off antibiotics. Then you can have things like contact dermatitis, tophaceous gout. And there are a couple of nice articles. There was one in Annals a number of years ago on Cellulitis Mimics. I'd encourage you to go and look at that. It's a great article. There's other things that can cause it. But I think in conclusion, antimicrobial use, it really drives resistance. Stewardship is important to maintain our antimicrobials. Use in SSTI probably can be improved in most places. And we really need to consider the epidemiology. So if you have abscess, you have pus, it's probably MRSA, drain it. If there's cellulitis, it's beta hemolytic strep, treat for that. If they're not improving, then you can consider MRSA. Necrotizing infections, polymicrobial until proven otherwise, treat that way. And the IDSA guidelines are actually really, really good here. And with that, I'll finish up and open up for questions.
Great talk. Great talk. Tell me, you said Bactrim 1 or 2 twice. Are you talking about the DS or the regular?
The DS, yes, I'm talking about DS, right. And I didn't include this slide, but just to throw another nugget out there, it turns out, we've always thought Bactrim wasn't active against beta hemolytic strep. Based on some data from the 1940s and 50s, it turns out it may be active against strep. And based on susceptibility testing, it appears that most beta hemolytic strep are susceptible to Bactrim. Now, we haven't had any clinical trials, and so I'm not advocating Bactrim for your beta hemolytic strep infections yet, but I think in the next 5 years, we'll probably see that confirmed. I cut that slide to save time. Other questions? All right. Good. All right. Thanks, guys. Thanks for having me.